everyone. Happy evening. This is Kate Copeland, and welcome to a community health talk about bladder and bowel control tonight. Before we get started, a couple things. I want to thank Axionics, who has helped us put together this night. I'll introduce myself as well. My name is Kate Copeland. I'm a urogynecologist at Urology of Indiana. I also am the co-director of urogynecology at St. Vincent, Indianapolis, and the director of the Pelvic Health Center at St. Vincent and Carmel. I don't know if I need to, but I feel like I should say that I am on the speakers board for Urovant, although I don't think that will influence what we're going to talk about tonight. All right. Next, please. All right, so I like to call this talk Eye Leak. It seems a little bit cooler and more modern than alternatives. We can go ahead and go on. All right, so the goals for tonight, we're going to talk about different causes of bladder and bowel symptoms, specifically incontinence or leakage, how we diagnose those, different treatment options, and then when possible, talk about some ways that you might be able to prevent these. Okay. I should comment, we had a little technical issue that I have to ask someone else to push the slides, so you'll hear me saying next a lot. So there are two common causes of incontinence in women. We're going to start with stress incontinence. Stress incontinence is the leakage that's not associated with urgency. This is more the movement, thought of the jumping on the trampoline, the coughing, specifically the movement, pressure on the bladder with no urge to go. Okay. If you want to visualize it, it's really not a problem with the bladder. It's a problem with the tube you urinate through called the urethra that's on the bottom of the picture here. It runs in women along the top of the vagina, and when it's doing well, it closes tightly so that when you cough, jump, sneeze, the pressure that's on your bladder isn't stronger than the pressure that closes your urethra. In other words, when you leak with cough, that means that your urethra just isn't closing tight enough. Next. So when you look at what you can do for this, a lot of these are general health things that you'll learn for a lot of disease processes. Maintain a healthy weight. Your pelvic floor that supports your bladder and your urethra has to support the weight of your body. Don't smoke. It has a lot of problems with healing and tissue integrity as well as coughing. Avoid unnecessary heavy lifting. Interestingly, especially from a squat, when they've done studies, the worst kind of lifting for the pelvic floor is from a squat. Doesn't mean you should lift things and use your back because you don't want to throw your back out either, but just be aware of heavy lifting in general. Avoid constipation. Again, chronic constipation is bad for your pelvic floor. And then on a general idea, just to try to do some pelvic floor exercises, which we'll talk about here in a minute, to try to strengthen that pelvic floor. In fact, there's a term called the knack. That means try to tighten your pelvic floor when you cough, jump, sneeze. Okay. So what is your pelvic floor? So this is your pelvic floor. It's actually a bowl-shaped group of muscles, and they're really important. As you can imagine, as you're standing upright, as I said, this bears the weight of your body. It has a lot of important functions. Anything that goes in or out is controlled in some way by this pelvic floor. Ligaments as well, all surrounded by your bony pelvis. It surrounds the rectum or the anus, the vagina, and around the bladder, neck, or the urethra. So any issues with pelvic floor, whether it be incontinence of stool, incontinence of urine, and by incontinence, I mean leakage, or even difficulties with intercourse, can come down to the pelvic floor. Next. This is the same thing from the side. The red is the pelvic floor. And again, you can see here, because your bladder is in yellow, with the pink going below it, the urethra going through the pelvic floor, your uterus and your vagina being the pink in the middle, and then of course your bowel, your rectum, it being in the back. So you can see that all three of these, the vagina, the bladder, exiting through the urethra, and the lower rectum all go through that pelvic floor. So it's important to have a healthy pelvic floor for good bowel, bladder, and sexual function. Next. So what happens if you get a weak pelvic floor? Well, one of them is leakage with cough, jump, sneeze, because that pelvic floor that's supposed to help and support that urethra, that tube you urinate through, isn't helping it close as tight. And so when that loses support, you can lose urine when you cough, jump, sneeze. The other is what's called pelvic organ prolapse, which we're not going to talk about today, but that's when the vagina and the uterus tend to lose support and they come down and sometimes come outside the entrance of the vagina, causing symptoms. And the third is loss of stool or fecal incontinence, accidental bowel leakage. You have a sphincter, and that all is part of the pelvic floor and important for keeping in your bowel, your stools, when you don't want them to come out. Next. So what is a Kegel? So a lot of people tell people to do Kegels, and good evidence has said majority of women cannot. In fact, 1 out of 4 women, instead of tightening in, when asked to do a Kegel, will push. And if you can imagine, if you're trying to hold in urine or your bowels and you push instead of tighten, that works against you. So we're trying to strengthen and improve the tone of that floor, that bowl of your pelvis that surrounds all those important organs. Next. So a pelvic floor physical therapist will do a much better job than I'm going to do in describing him right now. And we often send people to pelvic floor physical therapy. And for stress incontinence, specifically, again, the leakage with cough, jump, and sneeze, physical therapy works on strengthening those muscles around that tube you urinate through, the urethra. Studies have shown that patients who have milder symptoms of stress incontinence have a very good chance of doing pelvic floor strengthening and curing themselves. Whereas patients with more severe symptoms, as you might imagine, may get some improvement, but less likely to get cured. But the way I like to think about it is there's 3 basic exercises that you can do at home. The first is to hold, count for 10, and repeat. So this is working on a certain type of muscle fiber of endurance. Now, again, you have to be able to find the right muscle. One good way to try that is to put your thumb into your vagina facing down and tighten. When you do this, you should feel that lift somewhat. The sides of the vagina should lift and elevate. You shouldn't move your stomach. You shouldn't move your butt cheeks. You shouldn't move your thighs. This really is an isolated event that works around the muscles that surround the urethra, the vagina, and the rectum. Next. The next is actually harder, I think. This is where you do fast flicks of the pelvic floor, where you tighten, flick, 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 10, and repeat. This works on a totally different fiber, and it is more difficult. So if you hold and count for 10, that's good, but doing fast flicks also works, and they work in conjunction very well. Different fibers, one working on endurance, one working on strength. Think of it as a sprinter versus a long distance runner. Next. And the third is an elevator move, where you envision mentally the top of your vagina as an elevator, and you tighten slowly. Picture it elevating to your belly button. Hold for a second, and then slowly release down again over the count of 10 up and 10 down. This works with different fibers and coordinates them. All of these you should do several times a day. Like any physical therapy regimen, it takes 3 to 6 months to really strengthen a muscle to its full capability. Next. So going back to leakage with cough, jump, sneeze, also known as stress urinary incontinence, abbreviated SUI, the second of 3 options. So the first is to strengthen the muscles of your pelvic floor, because all 3 things we're going to talk about to help you not leak with cough have to do with tightening the muscles around that urethra. Have to do with getting that urethra to close tighter. The first, exercises best with a physical therapist to help that urethra close tighter. Number 2, putting something in the vagina. Now, this seems kind of funny to some people, But if you picture a female's anatomy, and again, this is women, not men, the urethra, which is about 4 centimeters long, runs along the top of the vagina. As we mentioned, that's what holds in urine when you cough, jump, and sneeze. So if it's a little bit lax, then it will let urine out. You can wear things in the vagina that, if fit properly, they sit in the vagina and they push up against that top wall of the vagina and the urethra and give it a little more pressure to help it close tighter. The picture on the left is what's called a pessary. They're made of silicone. That's an incontinence ring, and an incontinence ring with support, the most common one. It goes in the flat side first with the little bump right under the pubic bone to sit under that urethra. The idea is, again, when you cough, that helps push on the urethra a little bit. These are something that are reusable. You wash and put back in. You can use every day, take them out periodically, wash and put back in, or you can use them only when you exercise. They're sized, you come in our office, and we have lots of nurse practitioners and physician assistants who size you, figure out the right size and shape, and then teach you how to take it out and put it back in. The middle one is an over-the-counter device that's similar. It's made by Poise, and it's called Impressa. And as you can see, it looks like a funny kind of scaffolded tampon. It goes in like a tampon. You can wear it up to 8 hours, and then you remove it. And it has the same idea, that it pushes up on that urethra to decrease the risk of leakage with movement. It comes, the original box, in a sizing box. You can buy it in pharmacies or online, size 1, 2, and 3. And then you figure out the right size, and then that's what you would order the next time. I think the biggest complaint I hear about this one is that sometimes it's dry, so pulling it back out through a dry vagina could be uncomfortable. I would recommend maybe getting a water-based moisturizer to put on it, just to decrease it, that it be so irritated. The third, and there's several, but this is one we like a little bit. You can order online. It goes in like a tampon, but it looks like a ring. It's hard to tell what it looks like. It has a string on it. To the far right on that picture low, there's a subtle little white double circle, and that's what it looks like. And again, it's something you wear in your vagina, pull the string and take it out. They tell you it's good for 30 days. I think it depends probably how much you use it. Next. So then beyond that, there are 3 options. So exercises, wear something in the vagina. Beyond that, now we're talking more surgical interventions. And there's lots of surgical interventions, again, all aiming to try to get that urethra to close tighter. The most common and considered by most to be gold standard is a mesh sling. And I should say that this is not what the FDA came out with concerns about. In fact, the FDA has said it's gold standard. It's an outpatient surgery by itself, takes about 30 minutes. It's been done in millions of women. It's been about 25 years. It's a great surgery. There are also fascial slings where you can take a patient's own tissue, either from the abdomen or the leg. There are laparoscopic or open surgeries where you suspend the tissue next to the urethra on each side. And there are bulking agents that you can inject through the urethra. We do a lot of these as well. Studies have shown they don't work as well as a sling, but they're not as invasive. And sometimes they're a nice option for patients. They're done with a little anesthesia, and you look in the bladder, and it takes about 5 minutes. You inject a gel around the urethra. Next. Important to know that there's no medicine for leakage with cough, jump, sneeze. And I'm sorry, I skipped that. Real quickly about slings, we already talked about all of this. This is what the mesh looks like. If you look at the picture, the mesh goes through a small, less than an inch incision in the vagina, and it sits under the urethra. It doesn't hold anything up. It's not near the bladder. It's under that tube that you urinate through, again, to help it close tighter when you cough, jump, sneeze. Another thing important to realize is it doesn't help with urgency symptoms. I have a lot of patients that come in with urgency frequency, which we're going to talk about, and want a surgery. But unfortunately, this is not what a sling is designed for. Next. And I think we already talked about this. Next. All right, so on to the next. So we already talked about that. I don't have to go to the bathroom, I cough and I leak. That's stress incontinence. That's the urethra not closing tight enough. The other very common cause of bladder issues in women and men is overactive bladder. An overactive bladder is a problem with the bladder, not the urethra. And its symptoms that include frequency and getting up at night, urgency, that fear that if you don't go to the bathroom, you're going to leak on the way, or even leaking when you can't get there on time, or even wetting the bed. Next. It's incredibly prevalent. Anywhere from 30 to 50 million people have it, and most people are well undertreated for this. There are significant studies that talk about how overactive bladder can adversely affect a lot of parts of people's lives. Next slide. People learn a lot of things when they have overactive bladder. These are all well-described behaviors because of overactive bladder. One of them is called toilet mapping, and I bet people listening know what this means. Knowing where a toilet is no matter where you are. Wearing dark clothes in fear of leakage so that it won't be embarrassing. Avoiding social situations, not doing the things in life that you want in fear of leakage. Significant decreased quality of life scores and decreased sexual satisfaction scores as well. Further, there are links with overactive bladder, especially at night, with patients having falls and even hip fractures. So this is, even though overactive bladder seems like in some people's eyes, it's not a big deal. When you take it as a big picture with all of these things, quality of life, changes in behavior, not doing the things we want to do, even issues such as skin breakdown because of pad use and falls, it really is a huge public health issue. Next. So here's what happens with overactive bladder. So this is your bladder. The tube at the bottom is your urethra. You can see those pelvic floor muscles on the side. They don't really have as big a role with the bladder function. So the pelvic floor is a bigger role with the leakage with cough in the urethra. The overactive bladder is the bladder squeezing like a water balloon when it shouldn't. So normally, if you feel like you have to go to the bathroom, you tell your body you don't need to go. The urge goes away. Your body, you had gotten a little signal somewhere between your bladder, your spinal cord, and your brain that said your bladder was full. You suppress it and tell it not now. You sit down, you tell it's time. That pelvic floor relaxes and the bladder squeezes. But overactive bladders squeeze when they shouldn't. And that's what causes that urgency and leakage. Next. So starting at the top, how do we treat overactive bladder? Knowing it's prevalent, we talk about what you drink, when you drink it, and how much. That's the first thing. So a few things to think about. Your kidneys are in your upper back, kind of under your lower ribs. So this really doesn't have anything to do with your kidneys, nor does it have anything to do with prolapse. So, and I understand this, I have a lot of people who think they have prolapse and that's why they go to the bathroom all the time, or they have urgency. And really, for most of the time, except for in extreme conditions, they're not related. And you could have prolapse and overactive bladder, but most of the time treating the prolapse does not treat the overactive bladder. And that's a hard concept to get through. But it's important as a physician and surgeon, I would never want someone to have surgery for prolapse only to realize afterwards it wasn't the prolapse, meaning something sticking or hanging down, that bothered them. It was the frequency urgency. So it's one of the things I try to make sure when I talk to my patients is that these are different. And you need to address them separately. So the first thing we do is talk about what you drink, when you drink, and how much. So as far as what to drink, there are some things that we know make it worse, and caffeine is the worst. So coffee, tea, sodas. We talk about the 3 C's: caffeine, carbonation, and citrus. Number two, moderate your fluid intake. This surprises a lot of people. I think we all hear to drink 8-ounce glasses of water a day, but it may surprise you that there's actually no medical literature to support that. And the majority of patients that are not in the heat or exercising, fever or diarrhea, don't need that much fluid. There's a couple medical conditions. There's some benefit of weight loss programs or kidney stones that can help, but even Weight Watchers does only 8 glasses. For majority of people who aren't exercising in the heat, etc., between 4 and 6 8-ounce glasses of fluid a day are fine. For some patients, cutting out bladder irritants and decreasing fluid is all they need to do to manage their symptoms. Don't smoke. Not only does it have bladder irritants and the chemicals, it's also a risk factor for bladder cancer. Manage constipation. Constipation has been shown in numerous studies to make overactive bladder worse, which seems a little quirky. However, the thought is that the nerves in the pelvis are not as sophisticated in some ways as we think they may be or should be. And it may be the pelvic floor perceives that there's something that needs to be evacuated if you're constipated, and it gets confused and gives you signals that you need to urinate. Maintain a healthy weight. There's lots of studies that obesity worsens overactive bladder. Unclear if it's the weight of the bladder, the weight of the body on the bladder, but losing weight can help. Keep a good blood glucose. If you're diabetic, keep it under control. This does several things. One, if your blood glucose is high, then you'll drink more. And if you drink more, you make more urine. Second, it also can affect the nerves of your bladder. Sometimes patients who have uncontrolled diabetes and get neuropathy, that affects their bladder. And when it affects the bladder, it actually makes it harder for the bladder to empty. So now you have a patient who may have some urgency, but they also don't empty well. And that's tough because if you always start with, let's say, 150 ounce cc's or a cup or two in your bladder, it doesn't take long to get you full and it's easier to leak. If you take a water pill or a diuretic, remember that works on your kidney, not your bladder. However, when you take it for probably 3 hours afterwards, you're going to make a lot of urine really quickly. That just pulls out extra fluid out of your blood. So you're going to need to time that so it's least disruptive of your life. Nothing we can do can change that other than having you near a restroom so that you can go more often, and then maximizing the ability to hold what you can. And we'll talk about that in a minute. Some of my patients like taking these medicines in the late afternoon. That way it doesn't affect their whole day, but it also doesn't keep them up at night. But that's something for an individual patient and also for them to talk to the prescribing doctor about. Interesting, like a lot of things in life, there are some studies that yoga, meditation, and acupuncture can help overactive bladder as well. Next. So we send a lot of patients to physical therapy for overactive bladder as well, but this isn't really for Kegels. So again, Kegels mean you have a strong pelvic floor. Might be part of this, but part of this is what's called urge strategies and bladder training. And urge strategies are how to teach you when you get that sudden urge, what to do. And surprisingly, it's not cross your legs and run. It is things called fast flicks of your pelvic floor, which we talked about before. This sounds a little funny because most people would think I'm going to tighten to hold it in. But fast flicks of your pelvic floor, it works to the benefit of some of the nerves that control your bladder. And think of it this way. Again, if you're out walking around and you get the urge to go, unconsciously, you tell your bladder you don't need to go and the pelvic floor kind of tightens up. And that sends a signal back to your spine, and your spine sends a signal to your bladder that says this isn't the time to urinate, and it relaxes the bladder. Because remember, when you have the urge, that's a muscle squeezing. If you do fast flicks of those muscles over, it is like sending a signal to that spine over and over again saying, no, 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 no. And if it works, you're not holding in urine, you're actually sending signals to the bladder to get it to relax. So you're working on some of those neural nerve pathways to your benefit. The other thing that works very well, and many of you probably know this, I think probably all of us have had this to a degree. I call it the keyhole effect. You're home, you put the key in the door, and you suddenly have to go to the bathroom. Well, certainly the key didn't make you have to go to the bathroom. There's something going on, right? You're not crazy. There's something between the brain and the bladder. So there are known distraction techniques you can do if you know what your triggers are, whether it be coming in the door, running water, getting to the bathroom and starting to pull your pants down. There are ways you can step back and do distraction techniques. And there's all sorts, counting backwards from 100 by sevens, thinking of your grandkids' birthdays, anything that takes some focus away from the fact you're about to go to the bathroom or you need to go. Next. The other one is bladder retraining. And this is for people who go to the bathroom very, very frequently, not because they have a full bladder, but because they have overactive bladder. And this takes probably months, but you slowly increase the interval between your urinations. So where you can safely go and not leak, I should say. So let's say right now it's every hour. Then you might say for the next week, I'm going to go an hour and 15 minutes. And then when you can do that very comfortably without leaking, then you go an hour and 30. It is a slow process. It's not something that happens in a couple weeks. All of these things are best done with physical therapy because it does take some coordination of the pelvic floor along with all of this. The last one that's on this, that's a little different, is called timed urinations. And this is for patients who either have slow mobility. I have a lot of patients who have walkers or bad knees, or if they have some memory issues and they just forget to urinate. It is a common thing to be sitting down and not feel like you have to go, and then you stand up and it's too late. So the thought is, if you can set a clock and go to the bathroom before that, so this is kind of the opposite of bladder retraining. So then you break that cycle. And the thought is also certain things like diabetes may not give you, because of nerve damage, the signal you need till it's too late. And you don't want to rush to the bathroom, especially if you have some mobility issues, because you don't want to fall. You want to make sure that you have a clear path to the bathroom. You don't want rugs you could trip on or other things. If you really have problems with mobility, especially at night, bedside commodes are A-OK and much safer. But timed urinations, especially during the day, can work really well for patients who just by the time they realize they have to go, it's too late. So we're trying to beat that, be it every 2 hours or 3 hours or somewhere in between. Next. All right, so as we move on to medications, sorry, this got moved around a little bit. It's important for me to stop for a second and say medicines don't take away the need to do everything we talked about. And what I mean is, if someone still drinks 3 times more than what they're supposed to, or a pot of coffee a day, there's probably very little I'm going to be able to do to help their incontinence. So overactive bladder is a chronic disease, and it means we throw the kitchen sink at it. We work on how much you drink, what you drink, physical therapy, not smoking, constipation, weight, all the things to get the best outcome we can. Medications. These are the gotta go medications. You may have seen ads for them. There are about 10 of them now. Most of them, well, I should say all of them, you have to take daily. You can't take them as needed, which would be nice, but we don't have a medicine really designed for that. It works directly, if you remember that picture, on that bladder muscle to try to relax it. The goal is to increase how much your bladder holds and decrease that urgency and the leakage with urge. Most of them you have to stay on for a while, 4 weeks, maybe 6, depending on the medicine, to notice any benefit, and 3 months full benefit. Next. So there's 2 classes of medications. The older class of medication are these medications, and I put their generic and their trade names. These are the ones many people have taken or have heard of. They do have side effects that, for a lot of people, make them difficult to take. Dry mouth, dry eyes, constipation, difficulties with near vision, and growing evidence of difficulties with memory and perhaps a link with dementia or Alzheimer's. It is a cumulative dose, they think. There are lots of medications that have, and for other indications as well, that have some anticholinergic properties. So it's not that if you put someone on it and they're on it for a while that they'll get Alzheimer's. We don't think. It's a cumulative dose. But we do, I think, as we're learning more, try to minimize these if we can. And there's currently a statement out from at least one professional organization to really try to minimize these in patients over the age of 70. Next. Beta agonists are a different class of medications. There are two, Myrbetriq and Gemtesa. They came out about, well, one came out 10 years and one 3 or 4 years ago. They're the yin and yang of the other medicines. The other medicines I showed you blocked contraction of the bladder. These promote relaxation. They work in an entirely different receptor, so they don't generally have the side effects you saw on the last page, and nor any concerns about memory. Like the other ones, these are ones you have to take every day. You probably won't notice a benefit for 4 to 6 weeks and 3 months full benefit. Next. So then what do we have? We have a patient, and we have lots that have done their lifestyle issues. They're not drinking too much caffeine. Their volume of fluid isn't too much. They've, they're not constipated. They're not, and medicines just don't work. What's the next treatment? The next treatments are what we call third line treatments. But this again, and I tell this to all my patients, is none of these things will work if we don't do all the things I've already talked about. The 3 third line therapies are Botox, which we're going to talk about, and then nerve modulation, either in the sacrum or peripheral, which means the leg. Next. So overactive bladder, again, is that bladder contracting. Botox, as most people know it as something people get in their faces for wrinkles, what it does is it paralyzes muscles. It's used all over the body. It's used for muscle spasms and headaches all over, and the bladder is no different. So this is done in the office through a cystoscope, meaning a scope that goes through the urethra, and you look directly in the bladder, and you inject Botox. It takes maybe 1 or 2 weeks for full benefit, lasts on average 6 to 9 months. We do a lot of it at Urology of Indiana. In fact, I should mention we have an overactive bladder pathway with nurse navigators that help patients all the way from the beginning when they just want to do dietary changes to if they move on to medicines, helping them figure out cost effectiveness and prior authorizations and moving them on to third line therapies as well as needed. But Botox is done in the office, and patients generally do very well. The risks are minimal, but there are risks of bladder infections. That's the biggest one. There's a risk it doesn't work, and there's a small risk that you have problems emptying afterwards. Next. So before we go on to the neurologic treatment of the bladder, everything we've talked about, I should say medicines and Botox, focus directly on the bladder muscle. We're trying to get that bladder muscle to relax through medications or Botox. Nerve modulation is working differently. It's going back and it's working on the nerves that control bladder function. So as we talked about, during your normal day, your bladder fills. You get signals through your spine to your brain telling you when it's time to urinate, and then the brain sends signals back to coordinate that, to contract the bladder and relax that urethra and the pelvic floor to allow urine to flow. That's the way it should work. Next. So an overactive bladder, in some people, there's probably some kind of misfiring between the brain, spine, and the bladder, wherever it is. And we know that's the case because we see it more often in patients who have Parkinson's, Alzheimer's, stroke, any kind of brain injury. We see it in some spinal cord injuries that they control the bladder, either its ability to empty or ability to hold urine. In some people, that may play a role in their ability to hold urine, and the part of may contribute to why they're getting urgency frequency leakage. Next. So there are two ways to do this. The first is to go through the leg. This sounds a little quirky, but it's not new. On the left, you're going to see that's the middle part of your foot, and the yellow is what's called the tibial nerve. It runs kind of behind that ankle bone on the inside of your ankle. Well, that nerve, believe it or not, goes back up to a nerve plexus near your sacrum. We call it the sacral micturition center, which just means it's controlling of your urination. And we know that if we stimulate this nerve, it can positively affect the ability of the bladder to hold urine and decrease urgency. So we've long done in our office posterior tibial nerve stimulation. Patients come in once a week for 12 weeks, then once a month. You put a small needle, like an acupuncture needle, but it's not acupuncture, right around that area. And it's connected in that little picture with the woman on the right. You can see she's got there's a little white box. It connects to a little nerve stimulator, and we stimulate it for 30 minutes. So 30 minutes once a week for 12 weeks. And then we go once a month. The picture with the leg shows something that just got FDA approved in March, and there'll be others coming out too. Instead of having to come back to the office multiple times, this is an implantable device about the size of a nickel that gets implanted in the same area, lasts about 3 years, and it intermittently will stimulate that nerve without requiring the patient to come back. We should be doing this soon. We're up and going. It hasn't been done in Indiana yet, but we're hoping to get that going soon. Next. And then one that has been around longer than the stimulation in the leg, and longer than Botox, and longer than I think all the medicines but two, is what's called sacral nerve stimulation. So you look at the little picture I put up there. That's your spine and your bladder, and it gives you an idea of the nerves that go back and forth between the bladder and the spine, both in your lower back lumbar and even lower in the sacral area. All of these nerves are really important for bladder and bowel control, which we're going to talk about as well. There are two companies and two devices that make devices for this. There's different ones. There's rechargeable, like a cell phone. There's non-rechargeable, where you just leave it in. The battery lives now are over 10 years. They're now compatible with most MRIs. They didn't used to be, which is nice. So we have a great improvement since these came out when I was a fellow. It's indicated, surprisingly, for 3 different things. The first is overactive bladder, frequency, urgency, gotta go, can't make it there on time, not controlled with medications. Insurance requires 1 or 2 medication trials. Surprisingly, it also has FDA approval for incomplete bladder emptying. Not due to obstruction, so not somebody who has a big prostate or has had prior surgery and they can't empty, but for someone has what's a bladder that doesn't empty, probably because of nerve damage, as we talked about earlier, whether it be back injury or diabetes, and the bladder has just kind of been like an overstretched balloon. It's lost its elasticity. And the third is accidental loss of stool, because these same nerves also control a lot of the nerves that control the sphincter and the lower colon. Next. So sacral nerve modulation works on the sacral nerve. If you look at the picture here, this gives you an idea. There is the flat, well, it's kind of curved bone at the very bottom above your tailbone called the sacrum. On each side, there's 5 holes. For this, we don't go near the spinal cord. There's a wire that goes in, usually the 3rd, sometimes the 4th hole, and it lays next to the nerves and has 4 little sites on it that stimulates the nerves that control bowel and bladder. The device that's shown over to the left is the smaller of the two. That's the rechargeable one. The non-rechargeable one is just a little bigger, and I'll show you that in a minute. So it's a two-step procedure, meaning that we're going to see if it works before we implant it. The first step can be done in the office, or it can be done under anesthesia, depending on patient preference. If it's done in the office, it's kind of like going to the dentist, because the worst part's the numbing, but you just put a little needle in through that and pass a wire. And then the patient goes home for 2 weeks with a little device taped to the back to see if it works. Actually, the trial, I'm sorry, that may be shorter, 5 to 7 days. If the patient prefers to have anesthesia, we go and we put the real lead in and we do a 2-week trial. Either way, there's a trial beforehand where patient can figure out, does this really work for me? If it works, then we go to the operating room, we make a little incision in that upper butt cheek region, we implant that little device, and everything's on the inside, and really nothing to do. Next. This is a picture of one of them. This is the Axionics. This one has a little fob and has a little device. This is the test stimulator time, and the wire goes in. And then you have a little fob where you can adjust. But as I said, this is for the testing. That white one is externalized for the test, but you don't have that once you have it in you. Once we place it, you just have a handheld device in case you ever needed to adjust it. But the goal is really, once it's in and set to where you need it, you don't need to do anything. Next. Here again is Axionics. There are 2 companies, as we talked about. Axionics is the only one that has a rechargeable. Both companies have a non-rechargeable, but these are their 2, and you can see the little silver ones are the ones that are implanted. The rechargeable device can last over 15 years. You put on a belt once or twice a week, have a little device, a thing against the device to charge it, kind of like a cell phone, although less often. The one on the right, you don't have to do that, and the battery life improves as well. And it depends on, once we get you set, how high the amplitude is on how long the battery will live. It's a little bit bigger than the rechargeable one, but unless you're a very thin person, most of us have enough tissue to make that go deep enough, usually about 1 inch, that it doesn't bother us. Next. All right, we're going to skip on now to accidental bowel leakage, partly because some of the treatments overlap. So accidental bowel leakage isn't as common as urinary leakage, but it is prevalent, and it's, as you can imagine, can be devastating. So there's different types. One's passive, meaning you don't have the urge, you just lose stool, it comes out. One is urge related. Oh, gotta go, can't make it, lose stool. When I see someone, we do a lot of things. We talk about what the consistency of the stool is, which is really important when we're determining how to treat it, and how much stool is lost when incontinent episodes happen. Get an exam of the anatomy of the anal sphincter, any neurologic influences, things like that, and anatomy. Next. So very similar to the bladder, the nervous system also works on the colon. As the rectum fills, there are receptors that signal back via the spine to your brain to tell you that you have something in your colon and you need to have a bowel movement. If it's not the right time, your pelvic floor stays tight. If it is time, the pelvic floor relaxes and the rectum contracts to push out stool. Again, that's how it's supposed to work. Next. So, conservative treatments for accidental bowel leakage. Remembering that the colon that pushes stool out contracts several times during the day, 6 to 15, most commonly in the morning. The most effective time to evacuate your bowels are going to be when you have that urge. So if you have the urge and you think, I'm going to wait, and later don't, and you're straining, Now you're not using the benefit of that colon contracting. You're just trying to push it out, and it's not nearly as effective. So trying to have a bowel movement when you have the urge. Also trying to have a bowel movement 30 minutes after eating, because there is a reflex between stomach filling and colon contracting. When you sit on the toilet, relax your stomach. Try to make sure your pelvic floor is relaxed. Some experts recommend putting your knees on a stool. There was actually something that came out called the squatty potty that you could put around the toilet. Put your elbows on your knees and try to relax and try to avoid excessive straining. Next. So if you have loss of stool, we hit it from several different parameters. The first is we want to maximize the strength of the sphincter. Now, by sphincter, what I mean is where your stool comes out, there's a donut-shaped muscle around that opening. It's called your external anal sphincter, and it is the majority of the reason you don't lose stool regularly. When you tighten that, like if you sit and think I'm going to tighten my rectum, it is that muscle you're tightening. It's also the muscle that can be injured in childbirth. But we can strengthen that muscle with the same Kegels we talked about earlier. And again, best done with a physical therapist. But if you do it at home, focus on the rectum, same 3 exercises. The second is biofeedback, and that's interesting. There's a very good study years ago that doing biofeedback with a physical therapist also is very effective for accidental bowel loss. Going back to the consistency of stools, there are several things to think about. One is trying to get the stools so that they are formed. Ideal, and I joke that it's always, the elusive log. We want a formed, medium, not too soft, not hard bowel movement. The sphincter will have an easier time holding in stools that are a log than they will pellets, because pellets can slip out, or loose stools. So trying to bulk up the stools, fiber, avoiding triggers that cause loose stool. If you got your gallbladder removed, talk to your gastroenterologist, because there are bile salts that can be taken that can help. And of course, if there's any change in your bowel movements or blood, or if you haven't had a colonoscopy, it's always important to stay up to date with a colonoscopy or colon test. Next. So I jumped ahead here, but probably 80% of the patients I see that have incontinence of stool, it is directly linked to chronic loose stools. So the first thing we need to do, best we can, is solve that. So as I said, keep a diary, look for dietary triggers, caffeine, high roughage, dairy, artificial sweeteners, there's lots. Sometimes people do well adding fiber, like Metamucil. Some people do better with a low fiber diet. There's a good study out there that says in patients who have medium or soft or loose stool, so just not hard pellet, a daily Imodium, which is thought of as a diarrhea pill, but it actually decreases significantly accidental bowel leakage. And I want to say that again. If you have normal, soft, or loose stools, and you lose stool, you have accidental bowel leakage, taking Imodium every day, even when you don't have diarrhea, slows down the colon and will decrease accidental bowel leakage. It's over the counter. You can start 1 a day. You can go up to 2 every day. It's okay to take every day of your life. And if you have bad diarrhea, you can take it as on the bottle more often. But taking it every day will help with that. Next. There is, just like a pessary, there is a device that you can wear in the vagina, more aimed for passive loss. Just like pessaries are for stress incontinence, cough, jump, sneeze, not for urgency incontinence. This is more for passive loss, meaning that that sphincter is weak, and as you're walking around, coughing, moving, stool slips out. There's a device called the Eclipse system that goes in the vagina like a pessary, points downward, inflatable, and it pushes against the back wall to help hold in stool till you're ready. There are surgeries for patients who have large anal sphincter defects. However, by and large, these have been replaced with nerve modulation because the outcomes are better with nerve modulation. But if I have a patient who has a very large sphincter defect, kind of a gaping anus, there is a role for bringing that back together. Even if I don't think that's going to solve everything, that may be part of her multifaceted repair. There's also bulking agents around the anus. I don't do those. I think there are some people that do. They've had ups and downs from what I've read. There's artificial sphincters that some colorectal surgeons do for dramatic cases. Next. But going back to sacral nerve modulation, if a patient gets through and they've maximized the consistency of their stool, strengthened their pelvic floor, and they're still having incontinence of stool, the data supports sacral nerve modulation, which takes us back exactly to what we talked about before. It's the exact same technology, the exact same placement. So I have a patient with overactive bladder and incontinence of stool. This is a great technology for them because it covers both. It is the wire in the same location. It's a 2-week trial. You decide whether or not it's worked, at least 50%. That's for insurance, but then to your liking. And if it does, you can then put in either the rechargeable or non-rechargeable device. It should be noted that peripheral stimulation like the leg does not have FDA approval for accidental bowel leakage, only the sacral one. Next. All right, so last, I was asked to make a comment about when to see a urogynecologist. At Urology of Indiana, we have 4, and a urogynecologist is either a urologist or an OBGYN who finished their residency in that training and then did additional years. So the total training track is 7 years to do urogynecology, also known as female pelvic medicine and reconstructive surgery. So stress urinary incontinence, again, if you have stress incontinence and you can't control it with exercises and the intravaginal devices either you don't want to use or don't work, that would be a reason to see a urogynecologist because the next treatment would be an intervention, injections, slings, things like that. If you have, gotta go, can't make it, and you've cut out, you've minimized caffeine, you don't drink too much, may or may not have tried physical therapy. Some primary cares will do that. Maybe you've tried medications and they didn't work or you didn't tolerate them. Some primary care doctors will do that. If not, if your primary care wants you to see us, we can start with medications and physical therapy, or you can do that with your primary care doctor. Either before that, if you need medicines, or if you have gotten past medicines and they're not working, please come. We'd treat lots of women with overactive bladder with Botox and nerve stimulation very successfully. And then again, accidental bowel leakage. If you have done what you can with dietary changes and strengthening, or you need to go to physical therapy, please come because we certainly can treat you with a lot of things, sacral nerve stimulation being the most common. Next. This is our team, my partners. We're all over the city of Indianapolis. We all do the same thing. If you are not sure what is causing leakage, please come see us. There are other causes that we didn't talk about today, and we'll figure it out. If you can't empty your bladder, come see us. And then, not related to this talk, but certainly if you have a bothersome bulge from the vagina, prolapse, it's what we do, and we would love to see you. And I think that ends our talk. Is there another slide? In summary, I think I said this. We have lots of new ways. It's kind of amazing since I started doing this, how things have changed. We had 2 medications and nerve stimulation in the back was just starting. No Botox, no new medications, no peripheral stimulation. It really has just been amazing to watch. Healthy lifestyle is important, but often not enough. So don't feel like if you have these issues that you're to blame. You're not to blame. They're amazingly prevalent. People just don't talk about them. and important. Just like all people, not all leakage and issues are the same. I thank you for coming tonight, this evening, and I wish you all the best. And please let us know at Urology of Indiana if we can ever help you. Good night.